orthopedic surgeon. I work at Georgetown Hospital, and my primary interest is in foot and ankle surgery, specifically ankle ligament reconstruction. So disclosures, I have no specific disclosures related to this presentation.
A little louder.
Sure.
Louder.
So what my topic today is in regards to foot and ankle surgery and updates in 2018. So what's new in 2018? Specifically, we'll talk about MIS foot surgery, cold therapy for foot and ankle surgery, the use of the internal brace for ankle ligament reconstruction, and we'll go through a few cases at the end as well. Can you hear me? Okay. So my practice has really changed in the last 6 months, just in regards to percutaneous and MIS foot surgery. The things that have made a difference in my practice have been use of the mini C-arm, which has been around for a long time, but also the introduction of small burrs to help with reconstructing the foot. So specifically mini C-arm, and we use essentially a dental burr and small picks to break the bones, which has made reconstruction of foot and ankle surgery considerably more minimally invasive, less traumatic for the patients, and it seems to be speeding up healing times as well. So at this point, I'm starting to tackle cases that previously I would have told patients we should probably just leave your foot alone and buy a wider shoe. So the MIS bunion surgery, so these are the kind of cases we're dealing with in terms of reconstructing the foot. So classic case of patient with a bunion and some hammer toes. And essentially what we're doing is we're going in and just through small incisions, breaking the bones in multiple places. So in this case, we're breaking about the first metatarsal, first ray, and then for each toe we're breaking about 3 bones, just pinning them in situ temporarily, pulling the pins for the toes after about 2 weeks and for the big toe after 4 weeks. And you can kind of see the progression over time. So that's pre-op, 2 weeks, and 8 weeks. And we're getting good results with this. So that's what's kind of new and rolling out in foot and ankle surgery. So again, patients with kind of these crossover toes. So previously, I would have said to patients, we can do a wild procedure, some big open surgery, potentially fuse the first toe, or maybe just amputate your second toe, and those were kind of the options. But now we're able to consistently get better results. So I would say for foot and ankle surgery, we don't have to amputate your second toe anymore to get a good consistent result. And then we're starting to deal with other things as well. So things like hallux varus, where you get the kind of metatarsus adductus and your toes are going all the other directions, and we're better able to reconstruct these as well. This is a patient at pre-op and 2 weeks post-op, and you can see just the small poke holes where those are just the small poke holes that we're working through, and we've gotten to the point where instead of even suturing them, I kind of just leave the incisions open because they heal. It's only a 2 millimeter incision, so we're doing this better than we used to do. For sure, and we're getting good results. Specifically for this patient, I just saw her back in my fracture clinic yesterday, and she said thank you because she no longer has to buy 2 sizes of shoes because her other foot was normal, and she had this foot with the hallux varus. So she used to previously purchase 2 pairs of shoes every time she bought a pair of shoes, and now she can wear regular shoes. So she was technically unshoeable in the past. So that's what's new in terms of the MIS foot surgery part. So what else are we doing that's different? We're starting to use a lot of cold therapy, and we're building that into post-op splints. If you've ever gone for foot and ankle surgery before, or if you've gone for surgery in general, you know that we're using a lot more cold therapy. The difficulty with foot and ankle surgery was just applying it and figuring out a way for it to penetrate the splint. So essentially what we're doing now is we're putting our patients into just a back slab that's open on 3 sides, and we're putting the cold therapy device on top. And we found that we've been able to cut the amount of pain medication that our patients use post-op almost in half at the 2-week mark. So typically we would give patients about 60 Percocet, and what we found is that it would decrease the amount of pain medications patients are taking in the post-operative period. So we're doing that as well, and we're also building it into cast boots and figuring out different ways of getting cold therapy onto patients, but at the same time trying to minimize complications. And this is the presentation that I presented at the OMA Sports Med conference But essentially, we followed 20 groups of 20 patients in each group, one with the cast boot and one with the cold therapy cast boot, and we found we were able to cut Percocet usage from, on average, from 48 to 17. So we were able to about cut it in half at the 2-week period. So that's something else we're doing that's different. Other new things that are rolling out, so there's been a lot of talk in regards to the internal brace and ankle ligament reconstruction. Essentially that's, I guess, an Arthrex proprietary device, and they use that to supplement the ligament repair. And our question was, can we do this percutaneously? And a few years ago we attempted doing this percutaneously. The standard Brostrom procedure is a good procedure, it works well. It's probably the standard procedure for ankle ligament repair. But the question was, can we do this just through percutaneously, just augmenting the ligament? So that if you use the internal brace and you do it percutaneously under fluoroscopic guidance, these are your post-op wounds. They're significantly smaller. And we're getting good results in regards to stability in the post-operative period. And we found that we were able to significantly improve the time, the rehab time. These are kind of cases where previously the patient's under fluoroscopic guidance with a stress test, the patient's ankle was dislocating quite considerably, and then this is post-op stress test, and the ankle's back in place. So those are the kinds of things we were able to achieve with a ligament augment surgery. I would say it's a good procedure. We found we were able to decrease the post-operative recovery time. There are a few downsides though, and one is the cost associated with it. So it is a more expensive procedure because we're using anchors and their fiber tape. As well, we found that occasionally you can over-tighten the patients as well to the point where they would have slightly more pain post-operatively and you had to go in and release it. So those are things to be aware of. I would say that it's a good procedure. And it can speed up your recovery time, but the standard is still the standard Brostrom repair. And we still use the Brostrom repair as our basic repair. And the reason for that is that, number one, it has a good consistent result. Number two, it doesn't over-tighten the patient. But we are using the internal brace for revision procedures for ankle stability when it fails. Any specific questions in regards to that?
I was wondering, Chris, I mean, if the recovery, so I guess, what's the, when you say recovery time is 5 weeks, is it recovery time back to ADLs, or is it recovery time back to full activity, or?
We were looking at ADLs, so the most impressive patients we had were patients who were construction workers. So the first patient I did was a bricklayer essentially, and he went back in a month back to work. And typically those patients would be off 3 months. So it did have significant improvement in time off work. The downside is you can't over-tighten the patient and then you have to go back in and release it.
So what do you do to prevent that? Do you from testing under fluoroscopy?
Specifically, yeah, you can test under fluoroscopy. That's one option. Specifically in the technique guide, it says to put an extra, like a coker or an extra device, so you don't over-tighten the patient. And when you put in the anchors, you have the patient's foot in plantar flexion a bit, so it's a bit looser when you put it in. But I found, so the good thing about the Brostrom procedure is essentially it finds its own tension at the end of the day. While with this procedure, like any of the previous augmenting procedures, they all had a tendency to over-tighten the patient.
I guess just to follow up, I guess my question then is, what about the use of this in the acute sort of grade 3 lateral ankle injury? Because I guess the recovery time conservatively might be potentially longer, especially I guess we talk about elite athletes, because we want to give them a more predictable recovery. What are your thoughts on that?
When I first was pushing this forward, that was our thought, was that, can we rehab patients acutely? And Duong used to make fun of me. He used to say that, you just want to operate on every patient, including the acute ligament sprains. And I guess there is that potential for that, and I'm sure the American guys will push that in the future. Whether it be adopted in Canada, I don't know. The reality is that the vast majority of ankle sprains will get better by themselves 95% of the time, as we were discussing. So the question will be in regards to how fast do you want to go back. So potentially in the NBA players, those patients might be patients who might want this. So Steph Curry or someone like that, if he sprains his ligament, if we can put in an artificial ligament and get him back on the court 3 weeks faster, and they can win the NBA Finals. Is that worth it? And the answer is it might be. So that'll be something I'm sure in the future we'll see more results for that. Especially if you're doing it percutaneously and through minimal incision. Some of these patients do really well, really fast. So we'll go through a few cases as well. So this is just a standard ankles case. So 18-year-old male, right ankle inversion injury while playing basketball. The injury occurred 4 weeks ago, and he's a lot of pain, unable to bear weight. On examination, the ankle stable, he has lateral sided crepitus and pain, and the MRI shows a lateral osteochondral lesion. So in this case, it's kind of flipped on the lateral side, so a lot of pain. I think the majority of us would try to treat this operatively after the imaging. So at this point, we'd send the patient, usually see a surgeon at this point, and then we'd probably consent the patient for ankle arthroscopy, microfracture, removal of loose body, and then potentially fixing the deficit as well if it's large enough, depending on the size of it. So that's a pretty standard or straightforward case. Any questions about that or controversy? No. Yeah, I think that's pretty standard. I think most of us would do that.
And what do you, it's retrograde because you obviously can't put a screw in it's a weight-bearing surface. Do you go from underneath the talus? Or from
in this case, I think majority...
It was a fixable lesion.
If it was a fixable lesion,
yeah.
So I haven't had great success in fixing these lesions, but the ones that we did do, we used small bioabsorbable nails, like the smart nail, and we just go through the cartilage on anteriorly.
Okay.
Instead of retrograde. Depending on the age of the patient and all those factors, I've had more success in general just with microfracture, removing the loose piece and microfracturing it.
Okay.
It depends on the size though. If it is over 2 centimeters, like definitely over 2.5 centimeters, you probably want to start looking into fixing it. But if it's like this, like 1.5 centimeters, probably better just to remove it at that point. Any questions in regards to osteochondral lesions? So just in terms of osteochondral lesions, the standard is still microfracture, removal of loose body and microfracture. That would still be probably the best treatment in the majority of patients. But there's a lot of things out on the market. There's different procedures like cartilage regrowth things and juvenile cartilage and things like that. But the evidence is equivocal at this point in time as to whether or not they work routinely. Second case was a 36-year-old female ultramarathon runner. The patient rolls her ankle and she rolls it when she's running on uneven ground. It's been ongoing for 1 year and minimal improvement despite 6 months of dedicated physiotherapy. This is a patient who wants to get better but can't. She's otherwise healthy, no medications, no drug allergies. On examination, the ankle's swollen. She does have pain over the ATFL, normal anterior drawer, but it does open with the Varus stress test. X-rays are normal, but the MRI is normal as well. So no osteochondral lesion of the talus, ankle ligaments are attacked. I guess the question is, where do we go from here? So patient has evident instability, but imaging is normal.
And such conservative is not working, like in terms of strengthening stuff.
Yeah, she's very frustrated. She comes in crying. These ultramarathon runners, yeah. When you see them, I'm sure you guys have seen them. They're really dedicated, and when they can't run, they kind of go a bit crazy. So they show up in your office, usually in tears. Question?
Does she actually have evidence of effusion in the joint on the MRI?
Pardon?
Is there evidence of a joint effusion on the MRI?
I think there was a mild effusion, but no, specifically the report said no torn ligaments, nothing like that.
She has like a hypermobility syndrome?
Her joints are pretty stiff, like her thumb, she can't touch her thumb to her forearm, nothing like that. Yeah, so she's not hypermobile. So the reason why I brought this one up is because there's been, and I learned this over time, but actually MRI is not for MRI is a great diagnostic test in ACL, for rotator cuff imaging, but it's not a great test for ankle instability imaging. So we know, sorry that slide's a bit small, but the specificity and sensitivity they found was only between 64 and 86%. So it's not a 100% test for ankle instability. And if you go back in the literature as well, going back to the early 90s, it was only 50-50. I think the imaging is improving with time in terms of picking up tears, but there's not a direct correlation between ankle ligament tears and ankle instability. And I think part of the reason for that is that the ankle ligament might not be completely torn. Just like an elastic band, if you stretch it out multiple times, it might not be completely torn, but it's still unstable. So they might feel that instability, and unless they do bilateral MRIs and compare them, they might not be able to pick up that subtlety. So ultimately, it lies with the clinical exam. Because I often get referrals in my office saying, "Please see the patient. MRI is normal. Where do we go from here?" And often with exam, and we'll go through that when we practice examination skills. But often it's often the ankle is unstable and the ankle ligament is loose, but just not completely torn. So I would say that's an important point to note. Any questions about that in particular?
Chris, very quickly, are you happy with your clinical exam? You don't need to do stress views or?
So the Americans are big on stress views, and it depends on the center. It depends on whether or not they have an X-ray tech who's able to do that. I would say the majority of sites in Canada do not have that available, so I don't ask for stress tests. And I think just with proper clinical examination, you can make that determination.
Could you do a reliable stress test with ultrasound?
Potentially, you could do it with ultrasound. It might give you more information, but I think with good clinical exam, you can answer that question as well. You just want to compare one side to the other with the ankle hanging down against gravity. And then I was thinking about all the different scenarios. I do a lot of ankle ligament surgery. I was just going through my database last night, and I recently completed my 500th ankle rostrum repair. So I was thinking of all the different scenarios. So these are things like ankle instability plus other scenarios. So we'll just discuss like the various things that can happen, I guess. So you can have ankle instability plus an osteochondral lesion. In those cases, I'd recommend that you do both. You fix both. If you discover that, you fix both things at the same time. Unfortunately, I learned that the hard way, where the patient had an osteochondral lesion, and if you just do a microfracture, it's a much faster recovery. So I left it. I left the ligament. But the unfortunate part of doing that is that the patient was still unstable, and I had to bring her back for surgery 6 months later when she still couldn't run. So if you see both of them, I'd recommend fixing both at the same time. So ankle instability with a normal MRI. If that's the case, re-examine the patient and see if they have clinical instability. As you see more ankle instability patients, you also see patients with ankle instability and CRPS or neuritis. In those cases, start all the non-operative modalities for the neuritis and the CRPS. Patients with ankle instability and arthritis, in those cases, you don't want to tighten them too much because they'll have pain afterwards. I also see ankle instability with poor diet. So I was talking with Mark about this earlier. It's really important. Ankle surgery, unlike, I guess, hip or knee reconstructions and things like that, really depends on the patient's ability to heal. So it's important to make sure the patient's eating a good, healthy diet, and they're able to recreate their ligaments and heal the ligaments back together. And then also peroneal tendon tears. And surprisingly, there is an association between Lisfranc injuries and ankle instability as well. But I think we've probably gone too far on this. Any specific questions at all, or?
Do you recommend any specific supplements or things like that for healing?
I haven't been. I just tell patients eat a good, well-balanced diet. I'm on an egg diet right now, so I just tell my patients, basically if you're going to eat something, eat like whole foods, eggs in the morning, that kind of stuff. Specifically, I do a lot of bunion surgery, so I need their bones to heal. I get them on vitamin D, and I get them to eat eggs, and specifically the egg yolk, because it has 700 units of vitamin D. I think we had a recent foot and ankle meeting, and we noted that there was a lot more stress fractures and things like that we're seeing in our patients among the foot and ankle surgeons. And we think part of that might be because patients, they're doing more concentrated sports now, and they're just sticking on one sport, so it's potentially they're indoors the whole time. So people who are playing like soccer indoor, like hockey indoors, gymnastics indoors. So at our last foot and ankle meeting, there was a discussion in regards to our patients becoming more vitamin D deficient and having weaker bones and seeing stress changes because they're not getting enough vitamin D in their diet. I don't know if that's been brought up in the sports medicine literature, but that was a comment made at our last foot and ankle meeting. Because we're seeing more of these things that we didn't see a decade ago. That's all. So we get a lot of our patients on vitamin D, good healthy diet, eggs, basic stuff. More questions?
I'm just wondering about your general experience with Les Frank injuries.
Yes.
Just sort of common associated things, pitfalls. I currently have somebody who's like sort of recovering, no surgery, but she has CRPS and
Yes.
some other interesting findings with her foot that I've not seen before. So just
Yes.
maybe just a quick overview.
Yeah, it definitely happens in conjunction. You want to treat the CRPS, so physio, desensitization, vitamin C, all those things, and hopefully it goes away with time. I usually start gabapentin, 100 milligrams, POTID, and if that doesn't work, try Lyrica as well. Sorry, what was yours? So I'm a big fuser of Liz Frank injuries.
This one wasn't done, but
Okay. So essentially what I tell my patients if they come in with a Liz Frank injury is we're going to try to treat this non-operatively for 3 months. And if it gets better by itself, perfect. But if it doesn't, don't worry, I'll fuse you. It takes about, the recovery from a fusion is about 3 to 6 months, so it's nothing to rush into. And what I found is that in the beginning I was very surgically aggressive and I would fuse everyone who came into my office. But as I get further along, less so. So I find I'm operating on half and treating half non-operative.
and what's your typical experience for sort of active, sport activities if they're not fused?
It depends on the patient and what their activities are. So it's typically the older patients with less demands that end up with they go back to their activities post-op, and then the younger patients, depends on if they're dancing and things like that, they might ultimately require surgery depending on how demanding and how much force is going across the midfoot. But with the fusion, it doesn't become an urgent thing, so you can put off when you do the surgery. Well, prior to that, we're doing the open reduction internal fixation, just fixing it with some screws and not fusing the joint. That you need to do on a more acute basis if you're going to do it that way. The association with the ankle instability is often when they injure their Liz Frank, they twist their foot in such a way that they sprain their ankle and they injure their Liz Frank. But they always complain of the Liz Frank first because that's the most pain, and then they complain of the ankle instability 6 months to a year later after they've healed their Liz Frank. More questions? Okay, move on.
Yeah, thank you very much, Chris.